Cardioversion is one of the most common procedures, not only in cardiology, but also in emergency medicine and critical care. And to get the highest success rate of cardioverting atrial fibrillation, energy selection is a critical component.
So in the study, we randomized patients to undergo cardioversion using either low initial and then escalating energy shocks if needed, and compare them to maximum fixed shocks, the maximum possible energy setting in the defibrillator we used in the study, which was 360 joules. We found that when using maximum fixed shocks, the cardioversion efficacy was 88% compared to 66% when using the more standard low escalating approach, a 22 percentage points absolute difference and statistically significant. Importantly, we included a number of safety endpoints, and there were no differences in any of these safety endpoints. With this study, we sent an important message that using high shocks for cardioversion is important to optimize cardioversion efficacy. The protocol of using low escalating was introduced in the era of monophasic shocks. Nowadays, we most often use biphasic shocks, which has been proven to be more effective, but also safer than the previous devices.
Currently, in this contemporary area of biphasic waveforms, there's a number of different waveforms. Our study addressed the energy selection, but we also know that you can have what we call biphasic truncated exponential waveform. That's a biphasic waveform. You can have a rectilinear or pulse biphasic waveform. Previous studies have shown that the pulsed biphasic waveform is not as effective as the two other biphasic waveforms. And we used a truncated exponential waveform in our study.
So with this study, we are suggesting a change in clinical practice to rather using the maximum energy available than using the low escalating approach, which has been used for decades since the cardioversion procedure was first described in the 60s.
I think another important element of cardioversion is the electrode position. In the current trial, we used anterior-posterior electrode placement, but it's actually an open question whether you should use another electrode position, and that's something we are currently investigating in another randomized trial aiming to include 500 patients.